Thank you. We'll open it up to the floor for questions. And I think we'll follow Phyllis's lead. We'll take one side first and then the other. Questions for our panel? Well, maybe I'll start. Could we? Oh, you have a question? Good.
Hi. My name is Terry Allen. I'm from the Cuyahoga County Health Department in Greater Cleveland and a member of the Roundtable. Thank you very much for your presentation and the passion and your commitment. I've had the pleasure of working with a number of community health workers in the Cleveland area. And one of the things I'm interested in from a workforce development standpoint that we're hearing more about, and we've seen this similarly from some nonprofit agencies that are embedded in the community, trusted, and have those existing relationships, as they want to develop agency to run their own businesses. They want to hire folks, and along the way, we've seen some foundations that support community health workers that would like to do that to grow their own business. We've seen from nonprofits situations where we've tried to support from the governmental public health side back office capacity building for program and fiscal support. So this business acumen issue, I think, is important, and I think it's a fantastic model, an opportunity for those that wish to build, to expand. And I guess I'm looking for what sort of resources might be available. We've heard about some workforce development options, but I would like to share those with these very passionate folks back in Cleveland, and I know this is a real opportunity issue and advancement issue that these good folks need support for. Thank you.
Terry, I just want to thank you for that comment and question, because I think with this movement, it would be very easy for big institutions and government agencies to think that they can become community-based organizations by hiring community members. Mm-hmm. And I just want to emphasize that we need both. We need institutions to have community members as their staff for a couple of reasons. One, because they need to be really integrated into the teams, and the institutions need to be competent and trusted and have good relationships and be able to reach deep into the community. So it's essential that they have community members on their team, and also because they have a responsibility, because there's a workforce that's needed, and institutions can invest in communities because employment and economic opportunity is a social determinant of health. So let's not forget that creating these jobs also improves population health. But we have an infrastructure, at times dying infrastructure of community-based organizations that really need to be lifted up and supported, and there's no replacement for having grassroots community-based organizations that themselves are another mechanism for reaching into community. So I encourage the institutional partners to both hire those staff and also form real meaningful and equal business relationships with community-based organizations and to support their capacity like you're suggesting.
Yeah, I'll just reiterate that the question you're asking, that really is exactly the point of the CCO investment in the Oregon Community Health Workers Association, because we agree. I mean, it's just too onerous to expect every community-based organization to develop those contracting mechanisms with health systems. So instead, what we've chosen to do in our state is create the Community Health Worker Association as the broker in that relationship. So we develop those contracting capacity and relationships in addition to the training for community health workers and supervisors, the support for creating job descriptions and seeking appropriate community health workers, and doing evaluation of the programs. So I'd be happy to tell you more about that schema during the break.
Go ahead.
Thanks. I'm going to be the Brian Castucci of this panel, El Provocateur. I don't know you, Brian, but you rocked it. So a couple of tensions. I mean, I agree and support everything that my colleagues have said, but I do want to just note a couple of tensions. I think we're on a talk today about workforce and population health, and we might need to figure out what is the main priority? Is it workforce or is it population health? Are we focused on training firefighters or are we focused on putting out the fires? My bias, and I'd be curious to hear what folks think, is that if we focus on putting out fires, we'll probably train really good firefighters. But if our focus is just about the firefighters, we may or may not actually be effective in putting out fires. So that's one thing. And then the other piece, just to go along with the question from Terry, is about, I think broadly empowering community members and community-based organizations. And the tension to point out there is between community members and community-based organizations. It's a little tangential to the question, but oftentimes community health worker programs are sort of operationalized, or even more broadly, institutional partnerships with community are operationalized through CBOs. And that's great, and that's, I think, a first step. But CBOs are often self-selected in their composition. And so you have, folks who are in leadership positions in CBOs, and they're not, the diabetic, homeless person who's really kind of maybe at the end user here. And so when we're thinking about engaging community members, let's remember to try to, use different approaches, not only CBOs, and I don't think anybody's even said this, but what we've tried to do, for example, is we interviewed 1,500 low-income individuals one-on-one. And not everyone is going to have to do that, but I think talking to the people that don't make it to the CBO meetings is really crucial, and figuring out ways of bringing those individuals up into leadership positions is another important piece, along with partnering with the formal organizations that already exist and do good work.
One of the things that I also think that it's really needed in order for us to be successful is probably some kind of development within the people that are going to receive us in order to integrate us, because it's almost like having the latest version of the new phone or iPad with all of these functions that has all this, they can be very helpful. But if you don't know how to use it, it's just another fancy phone. Therefore, there's a lot of things that we do as community health workers are part of the community. For example, when I went through the community health workers program, the first thing that we did as a community health workers was collect signatures in order to get sidewalks and lighting in our street, because it was needed in order to have people walk healthy in a safe place. How can the healthcare system reimburse that? How can they connect that? That is the challenge. But at the same time, I think it's something that needs to be understood in the receiving end, that it's part of what we do, of the nature of our work, and not limit us, because once I have experience working in the clinic setting that it's like, well, no, you cannot do that because there's no code for that. So I think, yes, I love the training that we receive, and I love the training of our supervisor, but at the same time, the bigger system, I think we need to get that support in education.
Thank you. Next question.
I'd love to thank the panel for doing a fantastic job of fleshing out an issue that's a core passion for me for many years. Just 3 quick points. In California, many of our best and most sophisticated community health workers and promotores are undocumented and don't have a high school diploma. And where we went in terms of our process going forward is to certify the training programs. As one of our best advocates, Dr. America Bracho, said, you don't certify your mama. And so it was important for the medical community to be confident that the scope of training that is received by the community health workers that supplements their lived experience prepare them to work with their teams, which leads to the second point, and it's absolutely central, and we continue to overlook it. And my colleagues at IPHI address this and are struggling with this, which is how do we train the mainstream organizations to really take advantage of what community health workers have to offer. And a third point, and maybe Noel, you can address this as it relates to Oregon in particular. There's an emerging model out there called the Pathways Hub model of community health worker engagement that involves community health workers being engaged through a separate 501c3 to work with all of the providers and payers in an area. That enables them to retain their agency, in essence, on behalf of communities, and also to move beyond individual patient care management to broader population health improvement. I'm interested in how you might be looking at that issue in Oregon, as well as in Maryland, where we have the all-payer system.
This is on, yeah. So since you called my name, I'll start. But I'm not really an expert in pathways, although we do have a number of pathways programs in Oregon. And I think the important thing about pathways, which is a model which actually started in Ohio and sort of inspired by Alaska and has quite a long history, is to think of it not as a payment mechanism, but rather as sort of just a way of dividing the work. Because I think if you think of it as a payment mechanism, it can have some actually deleterious effects of sort of incentivizing people to just pay for these limited actions, which is kind of like categorical model of funding, right? So that's my question about pathways. But I think that it can also have some benefits if it's not looked at as a funding mechanism. I'm curious about what others think.
Thanks. Yeah, I'm a big fan of pathways in terms of the meta structure. I think it's the way to, the hub is the apropos name for it. It's bringing health and social service organizations on the same theoretical framework, often using a technology platform. And you basically can track Mr. Jones across, okay, he's going to the hospital, he's being discharged, he needs housing, and the community health workers are the human element that helps Mr. Jones across this, entire spectrum. I agree that the discreteness of the pathways could be problematic. So I think that's a great meta structure. And then in terms of the implementation of the actual community health worker program, we keep going back to training. And I challenge folks to think a little bit beyond that, because yes, we need to train supervisors, but even bigger than that, what is the bubble of, a community health worker program that could be transported from one place to another? And that's essentially what we've tried to do with Impact, is create an entire ecosystem that you can put and plug and play into a UPMC or the state of Louisiana, or it's being replicated in the VA. And it kind of comes with the infrastructure that we've been talking about, not just the training.
Can I add one thing to that, Shreya? Because I just want to read you my favorite recommendation from our statewide needs assessment, and it is to spread the community health worker paradigm, which is community-focused, non-hierarchical, and values life experience throughout the health system and dominant culture systems. That's, I think, what this is about.
Thank you. Next question, and could you state your name and the organization you're from?
Yes. So my name is Sagar Shah, and I work at American Planning Association. And part of my question was answered when you talk about lighting and sidewalks. And that was one of my main question. What I would like for you guys to tell me is, I have limited knowledge of what CSW, what community health workers do, because my background is in planning. But it seems like built environment is an important social determinant of health. And when questions like that is asked by your patients, how do you respond? One example is you went and collected the signatures so that you can go to the elected officials and ask them for more sidewalk or lighting. How can planners help to maybe in the training part, etc., to enhance or educate community health workers going from like community health worker to community health planner? That would be, just want to know how can we help that way.
Well, one of the first things to come to my mind is supervision. I think that the role of the community health worker, we encounter so many different types of people with a lot of different issues. And our role is to get them to open up And when you get a person to open up, you never know which direction that's really going to go. I think that if you have, I can just speak for myself personally, I have great supervision who has helped me map out plans. We call it next steps. We can talk a lot. We're having some great conversations here today, and we're going to all walk out this room. What are we going to do next? And that's where I think it begins with each and every individual. What's going to be the next step? How do we plan that next step? What are you going to do on your part to execute that next step, to make a difference, a positive difference in that person's life? So that's my first response to your question.
I think we have time. Oh, did you want to go ahead?
I also wanted to add the fact that we have to build on the current relationships that we have and partnerships, because they are fundamental for community health workers to be at the table. So if a community health worker is at the table, for instance, in Richmond, we actually have subcommittees and committees at the state level where community health workers are part of that group. So it's important to be intentional, and that covers all the discussion that we've been having, that community workers are not limited just to the clinical setting, but also the social and planning and everything that encompasses public health. So again, relationships, because even if we don't have a perfect system internally, or we want to reach out to those partners, we still have to build those relationships and transition them and see what are the areas of opportunities and what we actually have been able to achieve in order to move forward and be able to be successful and thriving in the programs or systems that we are trying to change.
Thank you. I think we're out of time, but our panelists will be here, and I'm sure they'll be able to answer your questions. But please join me in thanking what a great panel and wonderful work. And I believe we're recessing for lunch. Are you going to talk?